Talk to Josh. I need to decide if they're not friends. It's just I don't really know.
All right, good morning, everyone. Welcome to the work group on corrections health care costs. This is the meeting where we hope to wrap up conversations around our last remaining agenda items. But as we have traditionally done, I will start by introductions. For the record, I'm Colette Peters, Director of the Department of Corrections and Chair of this work group.
State Senator Jackie Winters, representing the Senate.
Mary Butkin, representing AFSCME, Council 75.
Good morning, everybody. I'm Chuck Sparks. I'm with the Multnomah County DA's office.
I'm Kelly Ballas. I'm the Chief Financial Officer for the Oregon Health Authority.
Good morning, Fairborn Sparks, Oregon Youth Authority Director.
Hi, Sheriff Peck Garrett, Washington County.
Carl Miller, Correctional Officer, Oregon State Penitentiary.
And who do we have on the phone? Oh, I think we're mute here. They can't hear me. Here we go. Good morning. This is Colette with the HealthCare Work Group. We just finished up introductions, and I realized that we had those on the phone on mute. I apologize. Who do we have with us on the phone?
This is Julie with Senator Reese.
Hi, Julie. Welcome.
Thank you. Hi, this is Brian Never with the Oregon Health Authority.
Brian, thanks for joining us.
These are people who are going to testify.
Anyone else? Okay, great. So, since I am chair and have prerogative, for those of you that are wearing suit coats, I did remove mine. It is incredibly warm in here. We're working on the temperature. I apologize for that. And then also, since this is a work group on corrections, I do want to pause for a moment. For those of you that don't know, we've had a loss in the corrections family. We had the Deputy of Corrections in Washington, D.C., who was found slain in her apartment this morning, Deputy Carolyn Cross. And so if we could just take a minute. Thank you for that. I'll reach out to the director today and ensure that they know our thoughts are with them from Oregon. And it's a very harsh reminder of these difficult jobs and what we ask our public safety officials to do day in and day out. With that, we are going to start with follow-up items, as been our tradition. Mr. Robbins, we will turn it over to you.
Good morning, Madam Chair, members of the work group. For the record, my name is Steve Robbins. I'm the Health Services Administrator for the Oregon Department of Corrections. I'd like to begin this morning by providing you with an update, as we've done in the previous meetings, on Medicaid data that we've compiled. This is a chart that you've seen before. I won't go through each of the numbers individually, but just to call out the last number in green, we're right now up to nearing $900,000 in Medicaid claims that have been paid. Again, that doesn't equate specifically to savings for us. Our savings is actually larger than that. So we're estimating at this point that we're probably nearing around $3 million in savings. We're anticipating being about $6 million in savings by the end of the biennium.
So that's about half of what we projected, isn't that right?
That's correct.
Okay.
A little less than half.
So when we talk later about that $36 million deficit, $6 million of that will be attributed to this.
Correct. Next, after presenting the latest Pew report during our last meeting, I'd like to follow up by answering questions that were raised during that discussion. Director Puckshurst had asked about the data we utilize as DOC based on the Pew report's reference to other states that have consolidated financial systems. Our official book of record for DOC is SFMA, which is the State Financial Management Application, which is consistent across most state agencies. DOC does utilize a system that's called AFAMOUS, which is the Automated Financial Accounting Manufacturing Inventory System, for our own internal financial tracking, and it's from this system that we're querying information when we answer surveys. These two systems are constantly reconciled, so the information that's in them is in fact the same. In terms of our healthcare reporting information, DOC utilizes Correctional Health Partners, which is our third-party administrator, for reporting on off-site events, and AFAMOUS for all on-site event costs. So we are fully integrated from a financial perspective when we look across state agencies, but when we look operationally, we are not. On the operational side, we're able to obtain very granular information from our third-party administrator, all the way down to specific diagnosis, everything that happens specific to a claim. For those costs that are on-site, it's much higher level, just broad numbers across how we're doing on a business unit basis. When we do look, though, at specifically at the Pew report, it referred to the fact that states were consolidating systems. We did some follow-up there and found that their consolidation is actually something that the state of Oregon is already doing in terms of having the same accounting system across all agencies. Second, Director Peksharash had also asked about the breakdown of our cost drivers specific to those laid out in the report. If you remember, the Pew report talked about 3 specific areas of cost drivers. One was distance from prisons to providers and hospitals, which spoke specifically to our rural challenge here in the state of Oregon. Second was the prevalence of infection and chronic disease, mental illness and substance abuse disorders, and third, the aging inmate population. We'll be providing some examples next in the presentation specific to the offsite and the rural challenges that we have and what the finances are around some of that. Suffice it to say, we're obviously very interested in all 3 of these components as they impact us much as they do other states. We know, for instance, that we are utilizing a drug called Sovaldi for Hep C treatment, and the patients, we use that for patients that reach a certain acuity level. And that's a pharmaceutical that costs approximately $1,000 a pill. It's getting a lot of press across the country right now, and it's impacting us as well. For us, the potential price tag is in excess of $8 million just for the state of Oregon, just for that one drug. So we know it's a driver. Unfortunately, at this point, as we've spoken to at length in the past, we don't have the ability to query data very effectively on specifically how many Hep C folks we have, but we'll talk about that in a second here as well. A question did come up about what is DOC's hepatitis C rate in our system. All Hep C testing for our inmate population is voluntary. So we are not, in fact, testing every single inmate in the system. We compiled an analysis of
Deputy DA Sparks?
I just have a question on that. Since Hep C, as I understand it, is highly communicable, is that your understanding?
Madam Chair, DA Sparks, I'm not a clinician. My understanding, not as a clinician, is that it's transferable through blood, but I don't believe it's
Maybe readily communicable. It's obviously a concern anybody who's working with someone who's Hep C positive needs to know about. So perhaps, well, this just comes as a bit of a surprise, that there is no formal regime, and this is just clarification, not argument. There's no formal regime for testing for this particular illness when inmates come in.
Chair Peters, DA Sparks, that is correct. That is correct. It is voluntary. And just to give you some information on what we actually found from the 2013 information that we pulled, only about 20% of our inmates voluntarily tested. Okay? Of that 20%, only 20% of that 20% tested positive. And of that group, so 20% of the 20%, only 14% of that population was actually in a situation where they were a match for this very, very expensive treatment protocol. They were to that point in acuity. So when we look at our population, what we've had to do, to your question, DA Sparks, is try to extrapolate that, those percentages across the whole population. The challenge there, though, is that really shows Oregon with an abnormally low rate of hepatitis C. We feel that when we look across other states, it can be as high as 25 to 30% of the population, whereas in our case,
inmate population,
of the
obviously.
inmate population, correct. And in our case, when we do this extrapolation, it shows significantly lower. So that could speak to a whole number of things, not the least of which is who's voluntarily testing and who's not.
A question. do other states, or are there other states that require the testing?
Chair Peters, Senator Winters, I do not know the answer to that. I could query other states and we could find out. But I know that in most cases for something like this, we're not able to force inmates into any kind of testing.
I ask that because I think it's a valid question to raise, particularly given your population. And so, I think checking with other states to see whether or not it is mandatory or not, and if they're having some other ways of getting the inmates to be tested.
Mr. Robbins, can you, for the committee's benefit, talk about why we don't do mandatory testing? And then also, if you remember, 10 years ago, we were on a trajectory for a pretty serious increase in Hep C. And then we started our Hep C program with the health department and then brought in an expert internal to the agency. Can you speak to that a little bit?
Sure. I'll speak, Chair Peters, members of the work group, I'll speak to that second component first.
Okay.
We actually brought a doctor on staff who is nationally and statewide recognized as a Hep C expert, is actually going around the state performing biopsies for us, liver biopsies for us, which has caused a huge reduction in cost because we're not having to put those off-site. Also working in terms of what's the most current approach to dealing with the disease. Also was instrumental in bringing on, as we've talked about a little bit before, the chronic disease self-management program that Dr. Shindo has also brought into our system as well. So you couple all of these things together, and we are very comfortable that we are doing the absolute maximum that we can at this point specific to dealing with Hep C, because it is absolutely something that is a concern for us across the system.
Do you know what the incidence is of infection from inmate to inmate within the DOC, of obviously communication of the disease from one inmate to another, and or staff? Because obviously this comes as a surprise, and it seems to me that with this particular very serious life-altering disease, which is communicable, that there is no regime for, and obviously apparently no statutory authority for testing inmates who will be having physical contact with other inmates, sometimes violent physical contact, and physical contact with corrections personnel, sometimes violent.
Chair Peters, D.A. Sparks, to answer your question directly, no, we do not know, in large part because the testing is only voluntary across the population. So we do not actually know specifically if there's what any rates would be of inmate to inmate or inmate to staff, any of that.
So if two inmates are in a fight and blood is exchanged, saliva, body fluids, during the course of that fight, there is no testing of, let's call it, both involved inmates to see whether the inmates were exposed to anything that the other inmate might have carried.
In that particular case, once there's an incident, there is an avenue, and I think Council Van Valkenburg will enlighten us on this, on both questions, please.
Deputy DA Sparks, you probably are aware there's a criminal statute that allows for post-incident testing for certain types of bloodborne diseases, including Hep C. So that's in the statute now. There's also a civil statute that allows court-ordered testing. So my experience with the department is that both the correctional officer unions and the department itself have gone into court, have actually asked for DOJ support for those petitions to get court-ordered testing when there's been a bloodborne incident. So that post-incident authority does exist. You're correct that there isn't any broad general statutory authority at this point for uniform mandatory testing. What I don't know is if there are policy reasons why that is so.
For the record, can you state your name before you go
Jeff Van
further?
Valkenburg,
Thank you.
Department of Justice, General Counsel of the Department of Corrections.
Thank you.
Yeah. So I just thought I'd come up for that.
There may be a follow-up question if you can hold
might
on
want-
tight. Senator, did you have a question?
Well, we talked about post-activity, and I think the concern is pre to prevent what might happen post, and whether you know or not if other states, or if there are other states that have some statutory authority for pre.
Chair Peters, Senator Winters, no, I'm not aware of what other states are doing, but we could certainly inquire through ASCA, and I have channels with listservs with my counterparts in other states, so we can get a sort of a rough sense of that, I think.
Thank you. Ms. Botkin?
I have a couple of questions. My first question is, what are the upsides and the downsides of mandatory testing? And what, how do we manage, for lack of a better term, voluntary exposure, illegal tattooing? You know, one of the issues that has been brought up to me in several of our institutions is the idea of actually maybe legalizing the tattoo industry in the prison system as a way to control exposure to bloodborne pathogens for inmates, and changing the way in which we manage our tattoo industry in the system, which, I mean, you know, I understand it's an underground industry, but it is an industry, and we all know it is. And so how do we manage it? And, you know, is there any thought about doing something different than the way we're doing it now, which is to try and keep it illegal and therefore encouraging the risk of exposure to, I mean, not just Hep C, but other communicable diseases as well. You know, everybody wants to talk about AIDS, but Hep C is actually a bigger killer now than AIDS is. And so the question is, how do we get a hold of it? And I really am serious about what are the upsides and the downsides of mandatory testing, given the fact that once we know somebody has a disease, we have a duty to treat. And so what are the...
I'd be happy to take a stab at that, and then the two of you can back me up. So I think it's important for people to know that we don't have the ability to mandate any sort of health care for the adults in our custody without a court order. So that would have to be very specific to, this would require some legal change than one that we have currently been allowed. So I think it's important to understand that. Secondarily, knowing that, part of our Hep C and chronic disease management program has really been education, to educate the adults in our care and custody around what health benefits could be afforded to them should we know what disease they were faced with. And we've seen increases in those that are agreeing to be tested because of that education. So I think that's important for you to know. Secondarily, we are always vigilant about monitoring the safety and security of our prisons, and that includes the illegal contraband it requires to engage in that tattoo making in prison. It still happens. One of the probably major system changes that we've made in the last 2 years is that we no longer allow the adults in our custody to purchase CD players, which was the primary tool that they were retooling, if you will, to create a tattoo gun. So now they have the ability to purchase MP3 players, which doesn't have an internal motor. So we've been able to eliminate that. That being said, we know that they're occurring today, right? And so we have had conversations, and I welcome any recommendation or suggestion to study further, but we have had conversations in the last 10 years about creating legitimate certified tattoo parlors, both in terms of an inmate work program, because those are actually high-paying jobs when they transition back into the community. And I just learned last week Salem has a shortage of tattoo artists. But secondarily, because it would then create a legitimate, clean space for those tattoos. We studied it probably 8 years ago and decided not to move forward for reasons I'm not remembering. But I welcome any suggestions from the work group. Anything you want to add? Okay. DA
Just
Sparks?
needle sharing, and I just did a little quick research, and also needle stick injuries in healthcare settings. So someone's treating an inmate, doesn't know the inmate's Hep C positive, some sort of needle stick transfer. So it's not just tattooing, it's obviously a significant risk. And my memory, and I'll have to double check the statute, but my memory is the mandated testing is generally HIV testing, at least in the criminal code, and it requires an underlying crime where there is a known transfer of bodily fluids. And I think when you wind that back, I have not seen HIV or Hep C testing provided for in that statute. So I'd gladly review any statute beyond what you've cited, but the one in the criminal code, I believe, directly addresses HIV testing, which is not the subject of this discussion. I think that this, I mean, it's certainly worth looking into that something like Hep C, which is lethal and life-altering at the very least and very expensive, and also disproportionately present in this population. It seems to me that a recommendation for statutory change that that testing must be done as a sort of gatekeeper function for DOC to during the intake process. I would put that out there as a request that the committee consider it, and if seen as appropriate, recommend it.
Okay, before we move on, Ms. Botkin, comments from the work group on the suggestion to put out a recommendation that testing for Hep C become mandatory and reviewing the legal avenue to make that happen?
He had his hand up.
Well, my question was kind of answered, so I was just going to ask if you were suggesting that we actually put in like tattoo parlors in the institutions and sanction it. So the director answered that question for me.
And my only comment would be that I think we should look at what the legislative requirements are to do that through OCE or through some sort of more formalized process of, figuring out if there's a way to do this in a way that makes sense, is cost effective, and is revenue neutral, if you will. And then I want to re-ask the first question I asked, which is what are the upsides and the downsides of testing and mandatory testing, and what are the financial implications for that if once we know.
Chair Peters, Ms. Bodkin, if it's okay with the work group, what I'd like to do is actually meet with some of the folks on my staff that are experts in this field and compile that list for this work group because I know that they've seen this through their careers, what the positives or the negatives are, and get that back to this work group. I would also like to follow up really quickly, DA Sparks, on the needle stick component. That is something that we take very seriously with staff, and that is something that we definitely track. So we have all sorts of information on that, which I can also compile for the group and provide some information on.
Thank you.
All right. I think it's important, though, that the needle sharing, obviously needles can find their way into the institution or can find their way into the hands of inmates, and once they're sharing, that's it's seemingly the principal way that Hep C is transferred among people who are in the drug-using population, and an inmate may not even know that he or she is Hep C positive, and there they are sharing drugs, sharing needles with other folks, and those folks then become infected. It just seems like an important aspect of their health care that we should know about and manage.
Also, I think it's important that we figure out, well, no, let me start again. My understanding under current practice and statute, and Jeff, you can correct me if I'm wrong about this, if there is a needle stick and it's a staff person, the staff person has the right to demand testing of the inmate for any communicable diseases. Is that correct?
Chair Peters, Ms. Botkin, there is a civil statute as well as a criminal statute.
That's what I
I don't have it off the top of my head, but I know that DOC staff have availed themselves both on the civil side and the criminal side to get court orders for mandatory testing. The other thing I would add is, while I'm not here to give you policy advice, I think you should be aware that in all instances of a needle stick or some sort of exposure, bloodborne exposure, DOC's protocol forever and the clinical protocol is universal precautions. There's always a clinical response to it. I think that the clinicians at DOC that I've worked with over the years, if they were here, what they would say in part is, I know that even on the criminal statute, there's a provision for a 6-month retest.
Mm-hmm.
Now that the science is they don't want to do that anymore for some reason. I'm not quite sure why that is, but there's some clinical reason for it. They think it's unnecessary. So the science has evolved, the clinical medical response has evolved, and I'm not completely conversant with it, but I think it would be good for you folks to have some information about that.
I think that there are cases, and certainly corrections officers know this better than I do. I don't work there. But I think there are many cases where exposure to bodily fluids is sometimes not anticipated, and probably in the heat of the moment, I don't know whether the officer that was involved in the shooting at EOCI and tried to stop the bleeding of the inmate who was injured, whether or not that officer had the presence of mind in that moment of crisis to glove up before applying pressure to the wound. I mean, those are things that I'm just not sure that officers on the line in the pressure of the moment have the ability to do.
And we have an expert in the room, so if she would be so kind, Dr. Marcia Adams, who's the medical director for the Oregon Youth Authority, if you wouldn't mind coming forward and educating us on how Hep C is actually not transferred. I think that would be helpful for this conversation. In the meantime, Senator, you have a question for...
I have a question, and I'm going to go back to Ms. Botkin, because I think you're talking about the tattooing and a training program or possibility of, and so I think you want them to look at what is the feasibility of actually having a tattoo training program and what it would cost, and whether or not our institution can embark on that and then bring that information back. So I think we are looking at feasibility rather than
a mandate. Okay, great. Thank you for that clarification. Dr. Adams, thank you for joining us. For the record.
For the record, my name is Dr. Marcia Adams, Medical Director for the Oregon Youth Authority. I'm a family practice physician. I wouldn't say I'm an expert per se, but Hep C is transmitted through blood. It's not as readily transmitted as HIV. It's not transmitted through touching or even kissing. It's usually through blood contact. So, I don't know. Anything else you'd like to know about it?
No, I think that simple clarification
And it's
is
also
helpful.
through tattooing because of the exchange of blood.
Okay.
So.
I guess the question I have is under federal HIPAA laws, even if we had the information available, all the testing, that if we knew that the people were HIV or Hep C positive, how could we even use that? It would be sealed in their record, and...
No, may I?
Please.
Respond? Prosecutors deal with HIPAA all the time, and that's an excellent question. HIPAA is obviously a strict regime of governing and accounting for the exchange of healthcare information. But, for example, there's a complete exception to HIPAA for a grand jury subpoena. So states can create exceptions, statutory exceptions to HIPAA. Obviously, the exact pathway would need to be explored by the legislature. In this case, the grand jury subpoena process is a state-created exception. The states don't have to have a grand jury, but since they do, and since the subpoenas are available, the state can subpoena that information in, which we do because obviously defendants and victims can be hurt in the process or have medical issues leading up to or driving criminal episodes. And we, of course, can subpoena those in. Mental health records being a prominent example. If somebody has an acting out event, we can subpoena those. So I believe it's entirely possible to create a state exception to HIPAA that would track legislation of the type we're discussing here.
Thank you.
Chair Peters, members of the committee, Oregon already has a statute that allows certain uses of this information. First of all, fundamentally, understand that HIPAA, the federal HIPAA, does not apply to the Oregon Department of Corrections or to the Oregon Youth Authority. It's ORS Chapter 179 that provides for state medical information confidentiality and disclosure provisions. There's a specific exemption in 179.508, which is modeled after the federal HIPAA exception for certain types of disclosure when disclosure is necessary for health and safety of the inmate, for some issues of administration and a number of enumerated purposes, including criminal law enforcement reasons on the grounds of the prisons. I think it would be useful, frankly, if we had some additional DOC medical folks who are more expert in this area, because I think they've dealt with this issue for some time, and there have been I'm aware of internal policy debates about the use of this information, but I think it is a fundamental question is if the legislature were to require mandatory testing, what would the Department of Corrections or Youth Authority do with that information? When the clinical response is universal precautions after a bloodborne exposure, what more would the DOC do? Very few states segregate inmates. In fact, I think maybe no states now. Some states in the South used to segregate inmates based on HIV status. I believe there's been quite a bit of litigation over that, and I think that practice has been changed nationwide. Oregon has never done that. Oregon, in my experience, has taken a public health standpoint in approaching these bloodborne diseases within the prison population, working closely with Oregon's health department and their infectious disease experts. So, again, I don't know all the particular details, but what I am aware of is that DOC has consulted and their policy judgments have been informed by those public health perspectives. The other thing that you might want to know by way of background is that we had some very significant class action litigation some years ago on hepatitis C, which we settled. Again, the medicine has developed, many times over since we settled that litigation, but there continues to be hepatitis C treatment litigation across the country. As General Counsel for the Department of Corrections, I'm satisfied that what the Department of Corrections is doing on the inmate side is meeting Eighth Amendment standards and meeting our obligations under state and federal statutes.
Thank you. Senator, did you have something else to add?
No, not really. It could possibly be that this particular discussion may require broader discussion, as well as the issue of the tattoo parlor and training. I think that it's one that has a lot of statutory, a lot of ramifications, a lot of the what ifs, and it may be, in listening to the Attorney General, the Assistant Attorney General, I think it would cause for a lot of further delving into. That's just my take on it. But I do think that raising the issue of employment and training is one that when we look at the feasibility of that and whether it is you can do it without adding cost and some of those others may be worth the agency exploring.
And we've even talked about at the agency, if we were to do something like this, to include a tattoo removal program as part of the process.
And if I can recall my years up at, I'm going to date myself again, OHSU, which was med school at the time I was there, that the cost of removal is far more expensive than it is in putting the tattoos on it. And I'd always hoped that in the educational process, that before one received a tattoo, that they would be told of what if later you want to have this removed, what it's going to cost you.
Or what it's going to look like
Or what
when
it's
you're
gonna look
60
like.
as opposed to 20.
Deputy DA Sparks.
Just as I appreciated Mr. Van Valkenburg's rhetorical question, what more would the DOC do? And I think from the DOC's perspective, that question and answer make perfect sense. But I would respectfully suggest that what the DOC would do is they would first inform the inmate. Because if I had Hep C and didn't know it, I'd want to know it. Second, it would inform future treatment of the inmate, because undoubtedly that would alter the course of treatment in some respect, I assume. And then third, it could alter the course of treatment of other inmates. If, for example, someone came in and said, hey, I'm overdosed, but I just shared a needle with inmate A, and then someone goes to that inmate's record and says, boy, inmate A, guess what? So now inmate B, who's just shared a needle and overdosed, is looking at other problems beyond just the overdose. So I think those three things I would submit are future steps that could be taken with this.
Fair enough. Thank you.
I guess from a public safety standpoint, and you can carry that further, if an inmate is released and is back into the population, the public population, it's that also that there's risk if that person has Hep C and that becomes shared. So I think the question of one's knowledge and knowing is really very much needed, and here again, go back to education, and I don't know how much education that's done in DOC when individuals come in, and I know that you're talking about voluntary, but I also, can look at the other side of how aggressively are we doing that to make certain that, one, the person voluntarily does it, but two, also that the treatment is taking place, because we're looking at the Oregon Health Authority, we're doing a lot of work now to make certain of the health consistency both inside and out. And this is another one of those inside and out, I think, treatment modalities that we would want to make certain that exist. At least I'm looking at Oregon Health Authority sitting over there now, so.
Well, I would, Senator Winters, agree with you about the consistency. You're talking about the practice itself should be consistent inside and out, and I would agree in general, but I don't have any specific information about to share.
Okay, great. Thank you. I'll just recap what I think I'm hearing from the work group, that there's a recommendation that the Department of Corrections looks at a feasibility study on if we should create some tattoo program in the facilities in order to kind of eliminate the black market or lessen it, if you will.
Well,
And
I think it's two components. It's the component of the black market, if you will, but two, also the training, because if I heard it correctly, that someone talked about that there probably is a need from a business standpoint or an employment standpoint out in the broader community. Did I hear that correctly?
You absolutely heard that correctly, Senator.
correct.
So you're
and should we do it through OCE
Right.
or our other inmate work programs? So the department can look at that. I'm seeing heads nod, correct?
Just
In
a
agreement?
Quick comment, and I don't really, I'm not much into, I don't have a whole lot of knowledge about tattoos and their meanings and things like that, but I know at least in Oregon Youth Authority, one of the things we're concerned about is, the meaning of those tattoos and the gang tattoos, etc. And again, if we don't have great insight into those, I guess if you're going to establish a program, then you need to make sure that the tattoos are quote-unquote appropriate. And we do have a tattoo removal program. It's totally volunteered by physicians, and no public money is spent on it. So I don't know. I have mixed feelings about that. On the one hand, we want to give them tattoos. On the other hand, we want to remove them. So, just...
Fair enough.
Yeah.
Safety and security concerns would have to be a part of the feasibility study. Officer Miller?
And once you got past the OCE part of training somebody and all in the proper ways to give tattoos and the hygiene methods and all that other stuff like that, would we want to look at, I don't know if you'd have some kind of a place like VT hair at it, or trying to think how you would set it up after they were through the school, whether they could continue to give tattoos, or, like the barbers doing the blocks or something. I don't know how you'd make that work.
So some vocational certification. And I know that we've moved well into the weeds on this conversation, and I can see that Mr. Robbins is nervous. He's not going to get through the rest of his presentation by 10:30, but I do see two other recommendations, if I can, Senator, that I'm hearing from this work group. The second one is to review the statute to determine ability to test for specifically Hep C following an incident, either an assault or an accidental stick, just clarification there. And then do we also need to review what may be a potentially outdated statute because science has pushed further along than the statute. The third recommendation, to find a legal avenue for mandatory testing of all inmates at intake. I know that we studied this earlier when Director Williams was here. I can't remember what the report found, but we can look at that and add that to the list of recommendations. Anything else? Okay. Mr. Robbins, take us away. Thank you. I think that was a great conversation on a really important, and as DA Sparks pointed out, a very expensive conversation. So, thank you.
We'll get the money from the DAs.
I don't think that's what he was saying, just for the record.
Thank you, Director
He
Peters.
didn't hear that.
I didn't.
That's okay.
Got your back, you're fine. Mr. Robbins?
At our last meeting, I had offered to provide some scenarios that incorporated the various costs of providing off-site care to inmates that are unable to treat inside the institution. As you're well aware, every situation contains multiple variables, and one size definitely does not fit all. Before I begin with the scenarios, however, I'd like to provide some quick information on our spending outside the state of Oregon on healthcare costs. Biennium to date, so that's starting last July 1st, in 2013, we've paid approximately $3.1 million in claims to out-of-state providers in Idaho. Primarily, this is a result of treatment for our Snake River adults in custody in the Ontario facility. At the same time period, we've paid $2.6 million in claims to out-of-state providers in Washington, servicing our Two Rivers, Eastern Oregon, and Powder River facilities in Umatilla, Pendleton, and Baker City. By and large, these costs are incurred because we've sent the inmate to a local hospital first, and then that local hospital has referred the patient to an out-of-state provider after that initial assessment. They've found that they were unable to take care of the patient locally and had to send them to a facility that had greater capability.
Can I ask a question?
Of course, Mr. Vice Chair.
Can you tell me what hospitals these referrals would go to?
Absolutely. I'll give you a quick rundown. In Ontario, we have St. Alphonsus Hospital. That's a small regional hospital. That hospital refers to St. Alphonsus in Boise. If you look at TRCI, which is in Umatilla, they go to Good Shepherd in Hermiston as a local facility, and then they typically refer to Cadlick Medical, which is up in Richland, Washington.
Say that name again.
Cadlick, K-A-D-L-E-C, or sometimes to St. Mary's in Walla Walla, depending on what the need is. For Pendleton, EOCI, Eastern Oregon, they have a St. Anthony's in Pendleton, and they refer to, again, to Cadlick in Richland or St. Mary's in Walla Walla. At Baker City, there's a St. Alphonsus local facility there. Again, in that location, because of where they're located in Baker, depending on the situation, will either refer to Cadlick in Richland or St. Alphonsus in Boise.
Okay, thank you.
Senator?
Can I assume that, or not, that these are the only hospitals available in that particular area?
Chair Peters, Senator Winters, that is correct. I will put a caveat on that, in that there are other facilities, for instance, in Boise, But because of the referral patterns.
Well,
that we
because of
use.
the relationship between the hospital in that particular community and the hospital there, I mean, we can be very open and blunt about what we're talking about, because I just listened to the names very carefully, and there is a nexus. And so part of it, this is distance and closeness, correct?
Correct.
Thank you,
Correct.
Senator. Officer Miller?
Now, this is strictly the medical costs.
And
This
there's
doesn't include transportation or supervision.
On this slide, the one entitled Offsite Costs, Out-of-State Frequency and Cost, these are purely the medical costs. We're going to talk about some scenarios here in the next few slides where we can show you how quickly some of those other costs can escalate.
So follow-up question. So all of these would be, they're in 24 hours plus, so that's the Oregon Youth Authority's
Oregon Health Authority.
Oregon Health Authority, sorry, Fair Boris, I didn't mean to give it to you.
I
but
don't
the
have
Oregon
that kind
Health
of budget, Senator.
The Oregon Health Authority.
Chair Peter, Senator Winters, that is correct. This slide specifically refers to folks that fall into that category. We do pay, for instance, out-of-state providers that live in Idaho who are actually doing work for facilities in the state of Oregon. Those are not included here. What we included on this slide were those that were specific claims where we sent the patient out of the state to do the care.
So I'm going to, and maybe this is something that offline that you and the Oregon Health Authority may want to discuss, because I thought when we were creating the CCOs, we talked about the out-of-state, and particularly Idaho, because of this situation of where there would be individuals, and whether or not you have developed a operating agreement with Idaho from the Oregon Health Authority, and how that plays into this.
So in that area, the Eastern Oregon EOCCO has 12 counties in the eastern part of the state, and they do work fairly closely with St. Alphonsus and Boise. They have their own direct agreements with St. Alphonsus and Boise that the health authority isn't a party to.
And I think that that's good. I knew that Dr. Goldberg and I had talked about that, and also the issue up around Pendleton and Umatilla. And the question in my mind is to make certain that what the Eastern Oregon CCO, and as they're looking at cost containment, that this also flows with the whole objective with the cost containment over in Idaho. I don't want to give them an extra bonus and boost simply because we're talking about a different population.
Right.
Thank you. Mr. Robbins?
I had talked about the fact that I'd like to cover a few scenarios with you, just to give you a feel for what kind of costs we begin to incur depending on the situation with these off-site cases. The first scenario is for a patient that was admitted to OHSU with leukemia. In this case, for this slide, this was a 52-day event. Just as an aside, this same patient was admitted again for 34 days, and then again for another 35 days beyond this situation here. The hospital cost for just this 52-day stay was $725,000. In order to have security on site and to cover the work for the hospital watch staff, particularly overtime, we've estimated that the visit cost approximately $130,000 in security costs. Because of the inmate security level, we had to have 2 officers that are required during this hospital watch. So we're talking 2 officers every shift, 24 hours for 52 days. This inmate was housed at the Oregon State Penitentiary in Salem, so the prorated cost of shuttling the inmate to Portland and over around through the Willamette Valley is minimal. We talk about security costs now. We've got security costs that are involved with transport, but we've put those, for the sake of these slides, under security. So this is the $250 is negligible, really, and it's just the cost of fuel, basically, and a little cost of the vehicle.
Ms. Bodkin?
When you figure transportation, is this for the 24/7 2 staff, I assume, each shift? So it was only $250 Are you, I mean,
No, Chair
it
Peters.
seems low to me if you have two staff people going back and forth from Salem to Portland on a 24-hour schedule.
Yeah, Chair Peters, Ms. Bakken, typically in a situation like this, with the transport cost for this slide, it's purely the one time to get them up there and then to come back, and it's just the cost of the vehicle. The cost of the personnel involved are listed under security here.
And I think it's important for people to know, even though the inmate came from the Oregon State Penitentiary, that likely the hospital watch is being covered by officers from Columbia River.
Oh, okay.
Yeah.
Senator?
No, I'm just trying to wrap my little brain around 52 days.
Yep.
That's what I'm trying to wrap my brains around, and what was there, and probably needed a medical person to tell me of the acute myeloid leukemia. That's all.
Chair Peters, Senator Winters, again, not a clinician, but in my questions to folks around this specific case, it had to do with preparation for a potential bone marrow transplant. And in order to get somebody to the right level of health to be able to even get that transplant, that's what this visit was about, was simply trying to get them to a certain level of health where that's a possibility.
So, Mr. Robbins, that raises the question about, did this individual receive a bone marrow transplant at some point, or is it still pending?
That's a good, Chair Peters, Mr. Bellis, that's a good question. I'm not sure where this case specifically is at this point. I can follow up and get you an answer to that.
Because, you know, we often, as a legislator, I often get comments from the general public about, you know, care and cost. You know, and this one would be one of those that I'm sure I'd hear from my constituents on care and cost. And I think the question that's raised about whether the person actually did receive a bone marrow transplant is a valid one. Also in preparation, and I don't know whether or not what happens medically through the infirmary or off-site, if some of that could be the preparatory work to where you're not having that, because this, I guess the 52 days just jumped right out at me.
Senator, I appreciate that. I think our team really tries to staff these in a way where if the care can occur at the Oregon State Penitentiary, it does. And I will just remind the work group that we have a legal mandate to provide a community standard of care. And so I think this scenario and the next one that Mr. Robbins is going to show you, while not as grave in costs, another great example of how very quickly our medical costs can go up just depending on one inmate.
Chair Peters, Senator Winters, I'd also follow up on that, just to remember that we do use a third-party administrator, which does help us considerably in off-site case management. So they have nurses that are visiting the hospital specifically on almost on a daily basis during the week to try and determine if there's any possible way for us to pull that inmate back into the system.
I can appreciate that. However, it just begs some questions, you know, when those of us have to respond to the greater population as to costs and what have you, and that's why I raised that. And even though you have a third-party administrator, it's still looking at the overall system of delivering of medical care. And it's not just unique to DOC. As you know, this body has gone through the last, since 2009, in doing a lot of reforms, and that reform has included, you know, the Oregon Health Administration, and it's included everything from our bottom-ups to top-ups, and you name it, and we've been talking healthcare. And it is because healthcare cost, whether we're talking on the private side or the public side, has just gone out the roof to the point to where we're trying to balance between other parts of these systems. And this is another one of these balancing acts, I think. I just need to state that because people are listening to our conversation as we talk, and this body here is looking at how we can become more efficient and still keep within the principles of what we're responsible to do. I totally understand that DOC is in a very, and the Oregon Youth Authority and those in corrections are in a very awkward position, because on the one hand, you have some statutory requirements to make things fit that don't necessarily fit with the general population. So I'll state that for the record as well.
Great, thank you. I appreciate that very much. I'll just provide a gentle reminder to the committee. At this point,
We're not going to make it on time.
right, we had hoped to complete the follow-up items from Mr. Robbins. I want to make sure we have enough time to have what I think will be a rich conversation around early release. So keep that in mind as we push through this part of the presentation. While I don't want to stifle any dialogue whatsoever, I just want to be mindful of the clock. Mr. Robbins?
Thank you, Chair Peters. Maybe for the sake of time, I just provided 2 additional scenarios for you. We won't have to go through those slides in detail. Just to show you, though, the thing I'd like to call out is that when we go over state lines, we are required to have 2 officers. So again, that contributes to the cost when we have to take
Would
these
it be
folks.
more cost-effective if we did it in state?
That's always the first choice, Senator.
Because, I mean,
That would-
if I'm looking at Pendleton and Umatilla, I'm looking at transport to Portland or that general area. I raised that question.
So in the Pendleton and Umatilla, we would always do it right there at St. Anthony's in Pendleton unless Pendleton did not have the care coverage for that
And so
particular
if they
incident.
did not, could the referral be to Portland?
Chair Peters, Senator Winters, in some certain situations it is, depending on whether someone's being life flighted, depending on it really does depend, but I won't say that we always will use the same referral pattern. We will, in some cases, refer over to Portland if it's necessary.
Chair Peters?
Please, Sheriff.
Mr. Robbins, quick question. The hospital costs under these scenarios, or are they subject to Medicaid reimbursement under the ACA?
Chair Peters, Sheriff Garrett, they are.
Okay.
So I will skip through those scenarios and move quickly to rural recruitment. One of our primary strategic initiatives at DOC is recruitment, especially for the Health Services Division. The question was asked about rural recruiting for providers and the challenges we face in the outlying areas. It is absolutely a struggle for us. Unequivocally, this is a problem for us. We currently utilize headhunters. We currently utilize our own recruiting standards. But one of the things that I'm noticing in my tenure in this role is that we are competing against both public and private entities for these folks. And these folks that we're competing with clearly have a marketing component to what it is they do. At the Department of Corrections, at least at this point, we're more kind of sitting and waiting for applications to come in, and that's not really effective in this current environment. So we are currently putting together a plan that involves a number of things: marketing materials, a better online presence, partnerships with an Oregon National Guard and some other organizations as well, so that we can begin to hopefully start to attract folks, especially in those rural areas where it's more difficult.
Can I ask the Oregon Health Authority if they too are having the same problem?
Oh, absolutely. In rural areas?
Mm-hmm.
Yes.
So
absolutely.
maybe this is a subject for a joint discussion with DOC, the Oregon Health Authority, and the Rural Health Committee, Legislative Committee, because it is a problem statewide, both public and private, the need for providers, and maybe the recommendation from this group, this body, would be the concentration of that with all those players at the table to see how in Oregon we can do a much better job, whether it is coming up with some incentivized program or whether it is coming at looking the whole issue of that Texas did and looking at tort reform. But I think it is a serious, serious issue for the entire state, not only just DOC, but it is in our rural communities. So
Absolutely. I agree.
Everyone in agreement with that? And if so, I'd volunteer OIA to join the
I was trying to
conversation.
hide back here. but-
Sorry, I'm calling you out, Director.
And
Ms.
Madam Chair,
Botkin.
I would like to suggest that you also include OHSU as our medical school. You know, OHSU is, I am less than impressed with some of the stuff we've done with them around psychiatric care at the state hospital, but I do think that there's some opportunities there with educational costs so high that if doctors are prepared to set up a clinic in rural Oregon and agree to stay for a certain period of time, that there ought to be an ability for us to relieve or reduce their overall cost of education. But I do think we have to have a signed in blood oath from them that they are willing to open and stay and practice for a certain period of time in a rural environment. So, I mean, I just would like to encourage us to include OHSU in the discussions and see if there's a way to.
Great suggestion. We will add it. Anyone object to the current recommendation? Great, we will include it in the report.
The next slide, very briefly, just to follow up Dr. Knight Richardson and ask about the number of chronic disease self-management programs. These are the peer-to-peer programs we have. We have them in every institution in the state except for Forest River Forest Camp in Tillamook. Also, a question was asked around how much training is provided. It's 4 full days of training that are provided to those inmates for that program.
Thank you, Mr. Robbins. The next round of slides are going to prepare you all for the conversation around early release. These are the data points that you all wanted in order to have a more informed conversation around early release. I'll start by answering the question around mandatory minimum sentencing. The last time we met, it was requested of the department to find out how many states have mandatory sentencing laws, and we found that there are 29 states that have mandatory sentencing laws, as well as at the federal level. With that being said, I wanted to remind the work group members that with the passage of House Bill 3194, and as Governor Kitzhaber indicated, there would be an agreement to refrain from pursuing any significant sentencing changes in the near future. And I just wanted to make that point on the record for folks.
That was in blood oath.
Yes, it was.
During our last meeting, some questions were asked about the population breakdown specific to Measure 11 and non-Measure 11. So the next slides we'll cover quickly to cover that for you. In speaking with our research department, we determined after the question was asked that 42% of our populations of the adults in custody are serving under Measure 11 sentences, 22% of all women, and 44% of all men. I spoke at length with research about trying to pull the same information for those folks that are already out in the community under parole and probation, and their feedback to me was because of the various variables involved that they didn't feel any numbers they could get me would be of any value for this conversation. So we can continue to press down that road, but for the time being, they weren't comfortable with getting us that information.
Can you give us an ethnic breakdown? You don't have to do it today.
Okay, sure. Now, I apologize in advance for this slide because this is very small information, but really what I wanted to share with you here is it was something that we found was interesting, and that's really that if you look at the data, it shows that at about age 57 in our population, we see higher populations in Measure 11 than in non-Measure 11. So said differently, for each age under 57 years old, we see the non-Measure 11 population outpacing Measure 11. But over 57, we see Measure 11 offenders outpacing non-Measure 11 offenders. This demonstrates that when you look at our older population, they're more likely to be Measure 11 offenders, which isn't going to be a surprise probably to most folks, but the data actually bears that out. I did find it interesting when you look at these two slides, the distribution curves are actually fairly similar. It's when you get to that age 57 and older where you see the non-Measure 11 fall off more significantly than the Measure 11.
Senator?
No, I think we'll get to it on the when we start talking about the medical criteria for early release and what other states are doing.
Okay.
At one point in our conversation during the last meeting, the work group moved away from looking at Measure 11, and we wanted to talk about non-Measure 11 offenders. It was requested that we assess how many non-Measure 11 offenders were in custody that could potentially qualify for early release. And again, we'll have that conversation here in a minute, but I wanted to just give you a little bit of quick information here. We pooled information on those that were currently in an infirmary in our system and required what we would call nursing home level care if they were released. The total population of folks that fell into that category was 23. Of those, only 2 did not have a Measure 11 or other sentencing restriction. So again, only 10% in this category were capable of that. The question also came up about hospice during the last meeting. As of the 18th of August, we only had 2 folks in hospice. This flows up and down. Sometimes it's as high as 10. But as of this, it was 2. Question about advanced directives came up. Both of the inmates that were in hospice have an advanced directive. We don't have the ability to query it across the whole system, but we estimate that only about 1 to 3% of our inmate population has an advanced directive in place. We've gone through a fairly substantive education campaign on that. We've got posters up. We bring it up at intake. We talk about it. But I think it's much like the regular community in that folks don't typically really think about this until something goes wrong. And that's when we see them start to get involved with signing advanced directives.
I guess I've got looking at advanced directories, and I've done mine. It's, and there's so many decision points. So is that those decisions granted to DOC to carry out the do not resuscitate and some of the other things that are in the advanced directory? How does that work?
Chair Peters, Senator Winters, yes, if they have do not resuscitate components of advanced directive, that is absolutely something that we will comply with, and we actually list that. If you go into any of our infirmaries in the system, you'll actually see, you can see up on the board the signage that talks specifically about that.
Ms. Botkin?
Do family members, are family members informed of those advanced directives? Prior to, I sort of looked at Jeff for a second and I thought, if they've already signed an advance directive, then there's no sort of legal challenges that the family could pursue against the department, right?
Chair Peters, I'd refer to DOJ on what the...
I was looking to him to nod or shake. One or the other.
Counsel?
Again, for the record, Jeff Van Valkenburg, Department of Justice, Chair Peters, Ms. Botkin. Family relationship does not create a legal authority for the department to share medical information without consent or court order. It is unclear to me whether a advanced care directive would come within that. I would think it would, but I'm not certain about that. There may be some specific statutory provisions in the end-of-life care statutes for healthcare decision-making. I think there's a point of authority, and often that might include the family, but I'm not sure of the answer, but we can look that up.
But you understand my question.
I believe so. You want to know if corrections has the legal authority to share that with the family. Surely they can with the inmate's consent. The question is whether they could do it without the inmate's consent, and I don't know the answer to that.
Okay.
Thank you. Mr. Robbins?
The last follow-up topic in preparation for the next portion of our agenda is that we have provided you a piece of paper that's called the Criteria of Conditions to be Considered for Early Parole Release. This was a document that was created in partnership between DOC and the Board of Parole and Post-Prison Supervision in an effort to meet minimum criteria for consideration in the process as laid out by ORS 144.126. Again, the next presentation will speak to the entire process, but as Health Services Administrator for the Department of Corrections, I'd call your attention to number 1 and number 3 on this list. DOC Medical helps in compiling information. We're information compilers specific to these 2 criteria and providing that data to the agency leadership and eventually the Board of Parole as a part of the decision-making process.
I think that is a great segue, if the committee does not have questions for Mr. Robbins, to invite Madam Chair Ms. Yanas to the table.
Thank you, Mr. Robbins.
Thank you.
Welcome.
Thank you. Good morning. I'm Chair Christy Winges-Yanez of the Board of Parole and Post-Prison Supervision. And I was asked to come here today to talk about the Board of Parole's authority or process for handling these requests for medical release or early parole release under ORS 144.126. And let's see if I can do this right. Okay. So our authority and our process is governed in our administrative rules, Division 40 of our rules. We may consider reductions in prison terms when any inmate, regardless of crime commitment date, is suffering from a severe medical condition or is elderly and is permanently incapacitated and is unable to move from place to place without the assistance of another. And of course, that is a very high medical standard. In addition to the medical standards, I believe you are also aware, of course, of the factors that DOC has presented on the legal standards and those who are ineligible, which is, of course, a large segment of the population, both Measure 11 and those whose judgment indicates that they are not eligible for early release. And that is a large segment of the population, as you've just heard. I want to note that these requests, that when they make it to the parole board, it means that they are eligible. They've gone through all that process, and DOC prepares this report. It is extremely rare. I believe there have been times when the board has gotten 3 or 4 requests a year. I've been on the board since December of 2012, and we have not received a single one in my time at the board. Also, board members Thompson and Wu have been on the board for less than a year, so this board has never actually reviewed a request for medical release. So what I've done for you all today to provide information is an attempt to recreate history of what the earlier board might have done. Because these things happen very quickly, there's very little record of how exactly that decision has been made in the past, but I have gone through our archived files when the files I've been able to recover, and have tried to put together what I believe has been the process in our office. And certainly the big picture process I will speak about. So the manner of review, our rule says that we may hold a hearing, and I'm going to talk about that in a little bit, but the rule also provides that if a hearing may threaten the health and safety of the inmate or the board shall consider the reduction administratively and may grant it upon an affirmative majority vote. So what this means, again, I'm recreating this, but there are a handful of decisions that the Board of Parole makes that we make by what we call a administrative file pass. And what that means is we attach all the information that we have, we pull the inmate's file, and the board members individually read everything and then gather to deliberate and then make formal written votes and a decision based on that. So it all happens without the inmate present, without crime victims present, but with information that has been compiled and prepared for the board. So we also can request additional information, and that's something that we do. For example, on a parole discharge, we do that by administrative file pass, and we are frequently asking the parole officer for more information, receiving more information so that we can make the best possible public safety decision under the circumstances. Again, because of the medical constraints on these decisions, they happen very quickly. They are reviewed immediately upon receipt. I was able to recover files from a release that was done in 2009 where it happened after hours and a decision was made by the next morning. So again, being attentive to the medical situation and the imminence often of death in this situation, these happen very quickly. The orders are issued very quickly through a board action form, and that is the board's formal order, like a judgment from the court, and that's how we present our order both to the inmate and to the public, and certainly is the official parole decision, which is memorialized then in an order of supervision conditions. And this is true of all of the board's releases and any release from prison. The board works very closely with Department of Corrections to create a release plan and a order of supervision conditions. We work with both Department of Corrections as well as the field, the parole officer who's assigned to supervise the offender out in the community. Now, I can say with a medical release, and we did one that was not an early medical release, it was a regular parole decision on an indeterminate sentence. We had an offender who was in the infirmary at he was in Eastern Oregon, and the decision was to parole him on his sentence, and we worked very closely with DOC's medical to make sure that he was going to be housed in an inpatient care facility. We ended up moving his release date several times because, the care was falling through in the community. We had to make sure that he was going to a secure facility. So the board really does take a hands-on approach when we are trying to create a release plan. We rely, of course, heavily on Department of Corrections and the community as well. And I certainly believe it would be true that in any early parole release situation that would be the case. We would be making sure that somebody is going to an appropriate care facility or a place where they're going to get the care that is the reason for the release.
Madam Chair?
Yes, Ms. Botkin.
You said in the very, very beginning, your first statement, you said you may hold a hearing.
Yes.
Is statutorily you're not required to hold a hearing?
Chair Peters, Ms. Botkin, that is true. Statutorily, we are not required to hold a hearing. I'm going to talk about hearings in a minute because, parole release hearings are a very big deal. They do take a bit of time to put together, and I'm going to talk about why I believe we have not held hearings in the past. So I'll get to that momentarily. Yeah.
I have one other question, Chair Peters, if I may.
Please, Sheriff.
In the slide here, if a hearing, it says if a hearing may threaten the health and safety of the inmate or the board, what kind of scenario would a hearing threaten the inmate or the board? I'm trying to envision how that plays out.
Chair Peters, Sheriff, it's my understanding that has to do with communicable diseases, perhaps other medical situations. Again, I'm reading into the rule, not having been the body to write the rule, but I believe that's what they're talking about. When we're talking about severe medical cases, we're talking about diseases as well as security issues. But of course, in this case, I believe we're talking more about medical reasons. All right, so what information does the board review? I really can't stress heavily enough how much the board relies on the Department of Corrections as the information gatherer here. We receive a report, the one I reviewed on the most recent decision, which was in August of 2012. That report was more than 10 pages long. It included a medical status report and recommendation. It included a Department of Corrections review of the inmate, and that's going to include disciplinary issues, criminal history, and institutional history programming, that kind of thing. The report also typically includes input from the district attorney of the committing jurisdiction, as well as the sentencing judge. And the reports that I've reviewed, there has been mention of the victims in the case. In at least one case, it was the district attorney who reached out to the victims on that case. And I do want to speak about victims a little bit later on, but it's sort of a larger topic, so I'm going to shelf that if anybody has any questions. But it is Department of Corrections who is bringing all the information together for the board.
Yay, Sparks.
If I understand, Chair Winkish-Giannis, first of all, thank you for being here. If I understand item number 1 on the bullet points, report includes medical status and recommendation. Is that a recommendation from the inmate's DOC healthcare provider?
Chair Peters, Deputy District Attorney Sparks, yes, it is. It is a recommendation both as to, again, looking at the few examples I have, as to the level of care that is needed, what is the medical prognosis, and also what might best serve the medical needs of the offender. And also the ultimate question in these reports is whether incarceration is serving the purpose that it was intended for this offender. And there is a medical input on that. The reports that I've looked at, there are several authors for each of these reports. You have a section written by the medical staff, you have a section written by the operations staff and security staff as well. So that it does include sort of an overview of what the Department of Corrections sees as the needs of this offender.
Who makes the philosophical determination as to whether continued incarceration under the circumstances, is serving the needs or the purposes for which incarceration was initially imposed?
Chair Peters, Deputy District Attorney Sparks, the ultimate decision is made by the Board of Parole. I will say that the Department of Corrections does make a recommendation as to their belief and from their point of view, and that is made by the Director of the Department of Corrections in conjunction with the medical and security staff. So you have a multi-level review of the case, but the ultimate decision is made by the Board of Parole. Does that answer your question?
It does, and obviously the multi-level review has no formal requirement for victim input, DA input, judicial input.
Chair Peters, Deputy District Attorney Spark, that is true. There is no formal requirement. And again, because I'm recreating history here, I am not sure to what extent, these factors have come into the ultimate decision-making process for the board. Again, I'm going to talk about this later, but I can tell you right now that this board believes very seriously that victim input improves our process and district attorney input improves our process, and that is absolutely a part of all the decisions that we make at the board. So
I've certainly seen that to be true in the parole hearings I've handled in homicide cases. So, and I appreciate you mentioning that, and also the fact that that's how the board does its business.
Yes.
Thank you.
Can I just ask a little technical question, because we started this, talking about the fragile or those individuals medically that are so severe with, medical situations that they no longer would become a threat either to society or to themselves or to others. And we probably look at someone who is very, very deteriorating. What kind of standards do you have, or do you have, that you, as a guide, that when those recommendations come from DOC, that you can actually look at it and say, well, yes, this kind of mirrors what we're thinking about, or what should be in place? Are we that far in looking at the medically fragile individual? I think there's two categories, by the way. I think there's that one, and I think there's one that Ms. Botkin and I think about often that could be in a place where they may be at the old women's prison, because it's all on one floor, and they can all be taken care of.
I've sort of abandoned that, Senator.
I'm like an old broken record.
Yeah, the director has sort of beaten me into submission on that.
She hasn't worked for the senator yet. But, so where that if you've got, the individual who still needs care, but yet they don't fit the category of no longer being a harm to others. So do you have that kind of guideline?
Chair Peters, Senator, there is not a formal guideline of what those standards are, and that simply doesn't exist in the law or in our rules. Again, when it comes to the medical decision, I am not a medical professional. The other board members currently are not medical professionals. We are relying heavily on the Department of Corrections medical staff and their expertise, and when it comes to those medical point of view. Now, the board is in the business of making public safety decisions, and when someone presents a danger to the community, so we do have our own internal standards for that, but in terms of a formal standard, there is not one. And there is not one for any parole decisions in terms of, exactly what you are to consider.
Thank you.
All right, so I think I'm picking up on, okay. I'm going to move on to a brief mention of hearings. I want to mention hearings because the rule and the statute does provide that we can have hearings on these issues, on these decisions. Historical examples do show that the board has used the administrative file pass. I did not find a single example where the board held a hearing. And I believe that's the case because of concerns with timing and logistics. We do need to schedule hearings 90 days in advance to provide notice to crime victims and district attorney offices as well as the public. Again, that's also the board's regular calendaring. We do calendar hearings 90 days in advance, and we have a very busy schedule. Also logistics, the inmate at our hearings appears either in person or by video, and because of security and the way these things work, the video we don't take a video conferencing TV into the infirmary. The inmate has to be wheeled into a hearing room at Snake River, at TRCI, wherever they are housed, and then we video conference with them from Salem. So
What if they're bedridden? What if they can't get up into a wheelchair?
well, Chair Peters, Senator, that is exactly why we don't have hearings, I believe, because we cannot get them to that facility. So that is why we've been handling these administratively. At least that's my understanding. So, and that's exactly why. So I do want to say that if eligibility were expanded, if we're talking about people who aren't bedridden, who aren't needing to get out within the next week or so, I think the board really would consider holding hearings because, again, input is incredibly important to our process. These decisions are never taken lightly, and holding a hearing may be of assistance to the board in the future were we meeting with different types of inmates on these cases. So I just wanted to mention that's something that, of course, would impact our business and certainly is something that we have the authority to consider and would consider. I tried to keep my slides sort of brief here, so if you have questions, please do let me know. But I did want to answer what I believe are questions about victims' rights and medical parole. Again, there are very few examples of these medical early release cases, and I don't have exact data on which cases we contacted the victims. I will say that unlike ordinary parole decisions where we're looking at the aggravated murders, the dangerous offenders, and the folks who committed their crimes before 1989, frequently mentioned as the worst of the worst, I hear a lot. When we're looking at early parole release or medical parole, we're talking about the average Berg one in the prison, different types of crimes that the board doesn't ordinarily see. And these are inmates who would go on to post-prison supervision versus parole. They have determinate sentences for the most part. And I will say that on these sentencing guidelines and post-prison supervision type cases, it is much rarer for us to have a registered crime victim. Now in Oregon, crime victims' rights must be requested. And I know you all work in this system, so you understand that. But I will say that it's less likely for crime victims to request notification from the Board of Parole on a case where the inmate has a firm date going into the prison. So I wanted to mention that because when we're talking about involving victims in the process, we only involve victims when they have requested it. And that's for a lot of reasons, and that's how Oregon law works. So I will say that on some post-prison supervision cases, we do have registered victims, and we work with them when it comes to release conditions, release planning, where the inmate's going to go, what their supervision conditions are going to look like. So it's not that we never talk to victims on these cases, it is just rarer. So to avoid confusion, I did create a handout, which is a non-inclusive overview of our victim services. Of course, the sort of heavy victim services that we provide are when we're talking about parole hearings. You have an aggravated murderer who's up for release. At that point, we have a victim services specialist who is working with the victims well in advance of the hearing. We have notification. The victim services support is there before, during, and after the hearing. And that's the kind of support that we as a board provide. But when it comes to a medical parole release case, again, I don't have an example of us, providing that level of service to a victim because, again, that hasn't come up in my review of cases. So I realize that's not a very clear answer because we're dealing with a very small set of data here, but if I can answer any questions about victim services, either when it comes to medical release or general parole, I'm happy to do so. I'm also at the end of my slides, so if anyone has questions about our decision-making, I'm happy to answer them.
Not so much about your decision-making, but the issue of the medically fragile population and the issue of states grappling with healthcare costs across this country. And it's become one that, Pew and others in states have been looking at. And just want to know from the pro part of the system, whether or not nationally there have been some information that you gleaned or understand that we may not have here. I noted that I believe it's NCSL just recently came out with a report recently talking about public-private partnerships as it relates to the medically fragile, we're talking about, when I talked about bedridden cases and what have you, and I believe that, correct me, Colette, if I'm misstating, the state, whether it was Vermont or one of those states, have really embarked on trying to get at this particular issue. It's not only an issue of where we are now, but looking to the future, and looking at that aging population that will continue to age if we continue the trajectory that we're on. And taking into consideration Director Peters' comment that when the individuals come to us, they're 10 years older than what they actually are in age, so we can expect, as we plan ahead, what that population is going to look like if they're in your system. I'm looking back at 1989 for 25 years in Colette's system and what have you. So we're really talking about anymore how you fit into this and as a system, and whether or not your particular organization has gleaned some information nationwide as well.
Chair Peters, Senator, I know that this is a big topic of conversation nationally, internationally, due to the rising age across the nation. If I can start by saying that parole and the concept of parole is incredibly different from state to state, and our systems are so different when we talk about determinate sentencing versus indeterminate sentencing. You look at some states and they make a parole decision, a yes/no parole decision on every single inmate in that system. And so it's hard to talk about, how is medical different from regular parole when you have the parole systems that are so very different from Oregon's system? So I don't have a good answer as to what the national trend is, but I can say that I know that this is a big topic of conversation. I know of a parole board member in Louisiana who's doing a master's thesis on medical parole. She didn't have data for me at this point, but I know it is a big topic of conversation across the nation as well as internationally. But when it comes to standards, data, exactly what people are doing, it's very hard to come up with an apples to apples comparison because of the parole law throughout the country, it just being so very different from our own.
Thank you. Chair Peters, I have a question.
Please, Sheriff.
Chair Wingazian, is going back to ORS 144126 for early release for severe medical condition. There was two medical criteria which kind of triggered that consideration. The very first one was just suffering from a severe medical condition, including terminal illness. And we visited a little bit about this at our last meeting, and I recall when Mr. Robbins was describing kind of the practical application of the parole board around this statute and applying this statute, he used the term comatose and vegetative state. And I'm wondering if not that I'm ready to loosen, lower the standard that DOC currently has, or the parole board currently has. Is there perhaps some case law or some just rulemaking that makes the standard a bit higher than what I'm reading in the RS? Granted, I'm a lay person here, not an expert.
Chair Peters, Sheriff, I will say that our standard and our rule is whether they're suffering from a severe medical condition or is elderly and is permanently incapacitated, unable to move from place to place without the assistance of another. So we're talking about folks who can get around in a wheelchair but may need assistance. The comatose vegetative state is not the parole board's standard. I understand that might come into play with a lot of these examples, but when it comes to our rules, it really is about it appears to me it's about the ability to move around and to present a danger. And that's a medical decision that, again, we rely heavily on the Department of Corrections to weigh in on what the abilities of this individual are. Again, we don't make a medical determination. We make a public safety determination based on the medical information that we have. So that's my understanding, if that answers your question.
I think so. So the statute has an or between suffering from severe medical condition, including terminal illness. It says, or elderly and permanently incapacitated in such a manner that a prisoner is unable to move from place to place. Sounds like that's kind of linked. You link that together, perhaps?
Well, Chair Peters, Sheriff, I think suffering from a severe medical condition to the extent that they are not a danger, that they are not able to move. Again, exactly how we interpret that statutory language, I don't have an example in front of me,
Okay.
but it needs to rise to that level that they are not.
Gotcha. Okay, I appreciate that.
And that's, again, my understanding, trying to recreate history. So speaking to the best that I can on this issue.
Thank you.
Yes.
Any other questions for the chair?
Nope, but I'm trying to figure this one out.
Okay, well, we'll figure it out, but we'll let you off the hook.
I mean, seriously, I hope even if this body, and I think we need more clarity, but I think that it rises to the level of the national discussion that's taking place and the discussion that's taking place here, that even if we have to recommend that we continue this discussion, this issue is not going away. I think we can all agree that, and we don't know whether whether we need to do more or whether we leave things as they are. But I, as the only policymaker that's here today, when this discussion started in the legislative branch, this group was created to start talking about how more effective we can be cost-wise, at the same time making certain that we're keeping the public safe. I think we always have to remember those two pieces to this. And so when we looked at the fragile population, is there things that we can do and do it, and as well as keeping our general population safe and do no harm. So the do no harm is at the top of the food chain list, and then from there are there things that we can do to make certain that the person is ending the rest of their life knowing that we're still keeping the population safe, and whether the nursing home concept comes into play, whether some of those other kinds of things come into play with public-private, and I don't think we're ready yet with this body. I think there's a lot more conversation, and I think you see some nodding of heads that needs to take place before we're ever really truly there, whether from the pro standpoint or whether it from DOC's standpoint, and others. And I don't know how you feel about it, but I think here in Oregon that we need a lot more discussion on this particular issue.
Madam Chair,
Yes.
I continue to be really frustrated over the fact that we can, just by way of background, my mother-in-law suffered from late-stage Alzheimer's, dementia, whatever, and she was an exit seeker. And so we had to put her in a facility from which she could not leave on her own. It was, I told my husband, this is like a minimum security prison. It's nicer, it has prettier fences, but it is just like a minimum security facility where you can't get from point A to point B without some way to move. We were able to get a lot of federal assistance in her care, in her end of life. It is increasingly frustrating to me that we cannot do the same thing with severely ill inmates, that we can't put them in some sort of a facility where we can access federal funding and relieve some of the cost impacts on the department so that we can use those dollars for other programs and/or areas of the budget that need some support that we can't seem to get otherwise.
And I think, Ms. Bodkin, I understand your frustration, and I know that the senator shares it. I think the important thing to remember is that federal law prohibits us from collecting dollars when they are incarcerated. And so we would either need to release them through an early medical release process into the community, or then the handoff could be to the community and a private facility, or we'd need to change the statutory definition of what incarcerated meant, but it would still at the end of the day mean a sentence reduction.
And I guess I'm just saying that at the end of this work group, it would be really helpful if we could figure out what that roadmap looks like, so that we can, and I'm sort of looking at Jeff as well, so that we can, as people who may not vote on the policies, but at least try to influence those policies, if we could figure out a way to do this so that the needs of the community who are concerned about the release of these individuals are met, and the budget impact is is channeled a little differently as well. I mean, I think we need to get as much help as we can get to pay for these costs.
And I think that's what the department tried to provide, Ms. Botkin, is a roadmap. I think at the end of the day, we found that the road was very narrow and pretty bumpy. And so I would open it up to the work group. As we've presented to you kind of the, right now under the statute, how limited the few number of people are from this conversation. And then I don't want to forget the whole notion that when they get to that point in their care, we've already spent the hundred thousands of dollars on their medical, right? It's just that end of life piece. And so I'll let you off the hook, Madam Chair. I don't think anyone has any more questions.
Because I think there's two components, that prior to the end of life, you have, and we talked about the entity that's costing you some $40,000 a month. We're talking about the individual who's not going any, what is it, the quadriplegic. We're talking about, which is extremely costly to your system. Mm-hmm. And the question becomes, is there a way that we can continue to keep the public safe? Because that's at the higher art. And at the same time, be able to access those federal dollars in another kind of environment. And I think that's really the discussion. And I don't know what Vermont and some of the others have been able to do and still hold on to the individual and that safety piece that we're all concerned about. Mm-hmm. And so perhaps, that's why I said it may be some more conversation that is needed, and find out through NCSL or others. I'm certain that they've had the same conversation that we've had. Because I don't think that there's any state that want to put any entity out there in the community and put the community at risk. So, to me, it's kind of like, are there pathways that we haven't thought of, that we don't know? Are there some, whether it's statutorily, that needs to be done? But I can't help but think, with 50 states, and all 50 states are actually grappling with this particular issue. Oregon is not alone in this discussion. Internationally they're having this discussion, and I think, DAs are having this discussion. We're all having this discussion of how do we address this particular issue. So I don't want to, for us to think that, that we've done the complete job if there's something that we may or may not, that we may have missed. I guess that's where I am. Because I think we all know that that's out there on the horizon. Whether this body here, will be able to come up with a specific recommendation, I don't think so at this juncture, because we're headed into 2015. But does that mean that we end here without continuing this discussion and delving into what may be something else out there? And certainly the parole board needs to be a part of this, And whether it's mandatory sentencing or not, I mean, you still have a large population of individuals that you are responsible for. And that population is also growing in age. If we could all get a fountain of youth here and beyond that, what we don't have. And I'm a part of the chronologically advantaged group, Mary knows, and understand that as aging takes place, that the body starts to deteriorate. With that, Madam Chair.
Thank you, Senator. And I certainly don't mean to sit here and sound like a contrarian. So
That's okay.
I just want to remind people that we are not a Vermont. Vermont doesn't have mandatory minimums. We do. And so I know that there's been an agreement not to have any sentence reduction conversations in the coming years. And I think that makes this conversation complex and difficult. With that, I will turn it over to the work group to see if there are any recommendations around altering the early medical release statute as is, the process, or any recommendations as it relates to this topic.
I don't think that at this juncture that we talk about altering any statute.
Okay.
I do think that there is further conversation.
And I would agree with the Senator. As I look to your introduction on your draft final report, Senate Bill 843 was, the intent for this group was to explore mechanisms to significantly lower the healthcare cost to DOC. So, for me, the bottom line is how can we provide secure housing that costs less, than what it costs you now, and that's no small hill to climb. But we've taken a few steps, forward in that discussion, and it may well involve, not only the stakeholders that you described, Senator and Chair Peters, but the DA's Association, sheriffs and chiefs. I think there's some opportunity to get there, but it will take longer discussion.
Other comments? Director.
I would just reiterate that and say that even though I don't want to speak for the DA community and crime victims, my sense is that their priority is community safety and listening to the voice of victims and truth in sentencing. So having said that, clearly, in light of the deal that has been made, we're not going to make a recommendation to change sentencing. But even with that deal made, I think there may be pathways through discussions where those elements are in place. And if we can identify even a narrow, slice of this thing where all of those things are met and it results in perhaps significant savings to the state, we can at least suggest that the conversation continue and that those possibilities be explored. And in that way, we are not violating the trust that has been established between the various sides, but at the same time are being good stewards of public funds and, community safety.
Thank you. Jay Sparks?
If I actually have a few thoughts I would just like to put on the record. I think we're largely in agreement, but having worked throughout my career with victims, and I've lost count of how many homicide cases, but where I've talked to the families, and most of those cases resolve in pleas. Some of them are hard-fought battles, and you have a sentencing, and you can tell the victim, once that sentence is there, you explain the risk of appeal and post-conviction relief and federal habeas corpus, all of which lie over the horizon. But putting those aside, here's what we've got. And it's so important to victims, and not just society and community safety, but there is a resolution for victims. I've spent 15 years prosecuting child abuse, sexual abuse of children, violent physical abuse of children, and same thing. You tell those families, and often the children themselves, after they've testified, here's where we are, and here's the outcome. And if we were to take away at the end to let that person out, even for the most compassionate reasons in our minds, it really alters the landscape for victims. There is nothing unconstitutional wrong in at least my view, in someone spending the rest of their life in prison, even when they're very limited in their abilities. And a lot of the conversation focuses on the needs of the defendant or the so-called purposes of incarceration being met. But incarceration, as I mentioned, isn't just about taking somebody out of society. It's where the victims end up in this whole equation as well, and their feelings and the families. I think there is actually some value in somebody, and I'm not saying this uncharitably or unkindly, but there is some value in people spending the rest of their days in prison, even if they are sick at the end, because most of us are going to be sick at the end of our lives. I think it has already been pointed out, for example, the man whose bone marrow transplant was going to cost, and has cost society, probably by now, well over $1 million. I didn't hear that that person was a compassionate leave candidate. And so that cost is going to be absorbed regardless. That's just an example. And I think it goes to Senator Winter's point of finding different avenues to access perhaps federal funds. Some of the concerns I have is that the current system is in place. Even that system is, the criteria are vague. DOC healthcare providers who may have an emotional bond with the inmates are largely in control of information and recommendations. There's no outside counter to that. Victims are simply not involved in that process, not by law, not required to be. And I would read the Constitution perhaps somewhat differently, and the victim, when the victim requests notice, I think the victim is entitled to be involved, even if it's just a paper review. But I think that victim has a right to appear personally. And I'm not hearing that that's happening even under the current system, so I'm concerned about a future system. Of course, I'm concerned that judicial participation and DA participation also seems discretionary. I'm troubled by that. I'm also concerned that once you build in a challenge based on health condition, whether it's infirmity or whether it's medical condition, you are creating a right to get out from under a minimum sentence that will involve litigation, because there will be people who want to expand that definition. There will be aggressive, determined litigation around this. It's not going to be something that is either up or down based on the DOC's decision. There will be, as there currently are with parole appeals, there will be a tremendous amount of litigation. This area will become very complex, and we will be litigating what it means to be incapacitated or what it means to be not a danger to society. We'll also be litigating in the context of each case the philosophy of incarceration. And there will be lawyers and appeals involved in that process, and that will be costly, and it will create a great wear and tear and potentially disruptive and not helpful debate. I think it should not be lost that I'm not hearing that all inmates want this. If I were to view this from the point of view of someone who's spent a great deal of time in custody, I think that inmates may vary in their responses to that. So I'm not even sure that the inmates want it. If this process goes in, if we were to expand this, there will be instances of reoffending behavior. It's inescapable. If you do it enough, there will be reoffending. Some of these folks can be very determined. I've prosecuted people in their 70s and 80s for sexually abusing children, and I'm sad to say that's true, but it is true. There's no age limitation, and so that too there will be breakdowns, which would violate in a particular way the promise made to victims at the beginning that society is safe. I think that there are other facilities that could be built and maintained in the Department of Corrections. I think that this process, the difficulty of obtaining a minimum sentence, the protections in place, the statutory and constitutional safeguards that protect defendants, when you make it through all of those, it's a long journey with the victim's family, often up to 2 years. It's exhausting. And then to have something reopen as litigation at the very end would be, I think, very hard, because a lot of victims say, we want him to die right where he is. We don't want him to be out and free. There's no benefit to society in that happening. Given the age cohort we're dealing with, as has been pointed out, older inmates tend to be predominantly Measure 57. We're going to have more of that, because as this inmate population ages, we would have more litigation surrounding this issue. There will be more and more questions raised. And I think that once litigation entrenches itself, it will become an expanded and entrenched right, and there will be an entire area of criminal practice that sprouts up around this, and you will have people who can fund aggressive litigation to get their loved one out of prison, and you're going to have victims who don't have the resources to challenge that. So in short, I'm concerned that the system as it currently exists, while I respect the efforts and the difficulty of the decisions, it is a system that I think there are substantial questions about, and many people would raise questions about the system. This is not the time or place to do that, but I think if we were to transpose that system into a Measure 11 context, the battles that would be seen rightly over the horizon would be important, and I think that at the end of the day, the questions right now resolve themselves in favor of not taking this step. Thank you, and I realize that was a long statement. I apologize for that, but I wanted to put all those thoughts on the record, and I appreciate everybody's bearing with me on that.
I think they're very important. Thank you, DA Sparks.
Can I ask the Oregon Health Authority a question? You know, we have for Oregon Health Authority clients and patients below and above the line. And then I'm going to ask DOC if your provision of service when the person is, let's say, going into the hospital, meet that same criteria. Because your criteria for Oregon HealthCare and what we do there above and below the dot line, because I'm looking at your principle of community care. You know, and so we always think in terms of the Oregon Youth Authority, I don't know why I'm thinking about you this morning. The DOC, when we talk about containing cost, that's what we get back, community standards of care. Well, the Oregon Health Authority actually has established their standard of care for those individuals who are on the Oregon Health Plan. And how does that line up with what you do? Because I'm going back to those costs that were in your hospital and whether or not those really would have been paid. Because the public, and let's be honest, when we talk about, some of the political pushback that we receive is when there's articles out that come out and what have you, and John Q. Public says, well, I could have never done that. They would never have provided that for me. So is there an alignment?
No, there isn't, Senator, and I'll have these two experts come forward and talk through it quick while our other team is reminding me that we are 3 minutes over.
That's okay.
And that's okay. So I'll start by saying that the Oregon Health Authority is able to make decisions on what's above the line and below the line based on budget. We are not able to do that because of the community standard of care. There's clear delineation to the Department of Corrections in both statute and case law that wouldn't allow us to make that determination. Mr. Robbins, Mr. Van Valkenburg, would you like to add to that?
Okay. For the record, Jeff Van Valkenburg, Department of Justice. This was one of the areas that we covered at the very beginning when I gave my briefing on the Eighth Amendment standard to this work group. What I advised you at the time was that the reason that the Department of Corrections couldn't rely on the line drawing that the Oregon Health Authority does is because the Eighth Amendment doesn't permit that we simply can't draw these rationalized decisions based on budgetary resources and say we will pay only for this. That being said, let me bring a tiny bit of nuance to the notion of community standard. Generally speaking, in the corrections area, when we talk about community standard, what we're talking about is that our healthcare practitioners are held to the same quality and standard of care as any other practitioner in the community for providing the service. And so remember that the Eighth Amendment standard is that the government may not be deliberately indifferent to the serious medical needs of offenders. So the case law surrounds around what is a serious medical need, and in the range of available treatment, when is the government being deliberately indifferent to that need? So what I can tell you is many years ago, the whole notion of providing bone marrow transplant to offenders years ago, when that was deemed to be sort of an experimental process, there was a range of professional medical judgment that could be brought to bear upon whether the government was required to provide that. Within 10 years after the introduction of that clinical process, it was the norm clinically across the country. And the government was no longer able to say that there was a divergence of clinical opinion about treating that particular ailment with the cancer. So we see that all along in any number of areas. Organ transplants, that's an area. California provided a heart transplant for a prisoner some years back. Oregon has not yet done that. We've had litigation over liver transplants in Oregon. So it is evolving, but it's not the same as the legislature having the power to simply set this rationalized decision about above and below.
But you just raised for me the need for us to seriously, because particularly with your population, and we start talking about cost of care, and we start talking about aging and trajectory, and we talk about medical science as it has advanced. You know, I think that, you know, healthcare costs are not going to be diminished. If anything, we're looking at DOC. Unless we actually start talking about, you know, some different pathways. So I'm not going to talk anymore about this. And I think we're all saying the same thing. We just trying to figure out how to get there.
Agreed. Thank you, Senator. Aside from the request to have the Department of Corrections continue to analyze and discuss early medical release, any formal recommendations from the work group as it relates to this topic that you would like included in the final report?
I would request that we recommend that the legislature not engage in that step at this time. That until much more is known, information that we have before us is such that we should not move in that direction. We should not ask the legislature to move in that direction.
So a formal request from the work group not to expand early medical release at this time.
We don't have enough information.
Anyone object to that recommendation? Okay, it will be included in the report. Thank you, gentlemen. I will just wrap up quickly by saying you have attached a copy of the draft report. We will make modifications to it based on today's conversation. So I would recommend not wasting your time reviewing this one. We'll get a new draft out to you quickly. We would like responses back by October 6th. If you don't have any changes, please let our staff know that you don't. Otherwise, we will continue to nag you until October 6th for your recommendations and your changes. That way, we will have time to review in person. Remember last time, the timelines didn't allow us to do it. So this will allow us to review in person as a work group on the 20th of October. We'll be able to walk through the final draft of our work group's work. Okay? With that, October 20th. With that, any other, aside from reviewing the report, any other requests for agenda items at our final meeting on October 20th? Seeing none, I'd like to once again thank this work group for some very serious time and energy and effort and very rich conversations. Thank you so much. And with that, the work group is adjourned.
Thank you.